Hi everyone, and thank you ever so much for the invitation to speak at this conference on novel developments in syncope and related disorders. My name is Matt Reed and I'm a consultant in emergency medicine in Edinburgh and also an honorary reader at the University of Edinburgh. And I have a specific research interest in syncope and palpitations and also in other challenging areas of acute care where the innovative use of biomarkers, data and novel technology can aid diagnosis. Here are my disclosures. I was a member of the ESC task force on syncope back in 2018 and am supported by an NHS Research Scotland Career Researcher Clinician Award. The IPED, PatchDD and Aspired studies, which I mentioned, are all non-commercial studies independently funded through research grants. The objectives of this talk are to summarise the latest emergency department research in the area of syncope and related disorders with particular emphasis on syncope and palpitations, and I've trawled the literature over the last few years to bring you some of the most relevant papers. Starting with syncope first, this picture was clearly taken in a time when there wasn't a restriction to the number of relatives and friends you could bring to the emergency department with you. Kicking off with risk stratification, there have been a number of attempts to try and develop a risk stratification process by way of a clinical decision rule to aid emergency physicians decide who to admit and who can be safely discharged from the emergency department, with the San Francisco syncope score probably being the most well known. Fortunately, many are not validated or have not been shown to externally validate well and have been shown to not be sufficiently accurate for clinical use. The fact there are many of them shows that none are perfect, none have been widely adopted, and none outperform emergency physicians. Most lead to increased admissions and therefore defeat the object of applying decision rule. However, there is a new kid on the block. The Canadian Syncope Risk Score is developed by the Ottawa Group and consists of clinical evaluation, investigations, and the diagnosis in the emergency department. So the clinician has to decide whether the patient has a predisposition for vasovagal, so i.e. are the presenting symptoms all characteristic of vasovagal syncope? Has the patient got a history of heart disease? And also what's the blood pressure, the systolic blood pressure in the emergency department? The rule then calls on some of the investigations. So if the troponin is done, it asks whether the troponin is elevated above the 99th centile, whether the QRS axis is normal, what the QRS duration is, and also what the corrected QTc interval is. Finally, the tool asks the clinician to decide whether the most likely diagnosis is vasovagal, whether it's cardiac, or whether it's unexplained. And then there's this rather nice web-based calculator, which the link to is on the presentation there, where you can obviously go through and work out what the score for your patient is, and it takes you very nicely to whether the patient is classed as very low risk, medium risk, or high risk. Once we've applied the rule, this gives a Canadian score of between -3 and 11, which correlates to a risk category of very low, low, medium, high, or very high risk, as you can see in the table on the right. Now, the authors haven't really come down with a globally acceptable threshold admission score, and the reason for this is that they feel that thresholds for risk and admission are different in different parts of the world, particularly in North America compared to Europe and the UK. However, in some of their outputs, they advocate a threshold admission score of 0, so that they suggest that patients who score -1 or below on the Canadian score are safe to be discharged. Now, when we look at this in the external validation study, this equates to an admission rate of 44%, so less than the international average admission rate for patients presenting with syncope, which is 50%, but it does miss 9 serious outcomes, which gives an overall sensitivity of 93%. And this clearly, if you look at emergency physicians across the world and the acceptability of sensitivity risks in the emergency department, they tend to go for something around about 98%. So this is well below what we would accept. However, if you look at those 9 serious outcomes in detail, there were no deaths and there were no ventricular arrhythmias in anyone who had a serious outcome. So we're not missing serious outcomes here. If we adopt a threshold score of -1, i.e. we happily discharge patients who score -2 and below and omit those who score -1 and above, this gives a much better sensitivity of almost 98%, which is much more acceptable to emergency physicians. However, this comes at a cost and comes with an omission rate of 56%, which is more than the international average, and using this score would then, as with many clinical decision rules that have been derived in the past, lead to us admitting more patients. What the Ottawa group have done extremely well is have provided some excellent patient information sheets that very clearly advise the patient on which risk category they're in and give some kind of numerical visual aid to help them understand that risk, which is great obviously for shared decision making. And these are all available on the website that I gave you before. How does the Canadian score compare to clinician judgment in external validation? This paper is from the Milan Syncope group, who published widely in the area of clinical decision rules and was published in the Emergency Medicine Journal several months ago. They looked at 345 patients who presented from the 1st of September 2015 to the 28th of February 2017. They found that 12% of the patients had a serious adverse event within the first 30 days. That was 43 of the 345 patients. The area under the curve of the Canadian rule was 0.75 and the area under the curve of clinical judgment was 0.68. So the Canadian rule scored slightly better on area under the curve. So that's the balance of sensitivity versus specificity. They also looked at the risk of adverse events of patients that were deemed low risk by the Canadian rule and also low risk by clinical judgment. And they found that the risk in patients deemed low risk by the Canadian rule was 6.7%, and the risk of adverse events in those deemed low risk by clinical judgment was 2%. So therefore a slightly higher risk of adverse events in those who were deemed low risk by the Canadian score. And they found that the sensitivity associated with these was 70% for the Canadian score and 95% for clinical judgment. So therefore, the sensitivity of clinical judgment was far better than that of the Canadian score. This table summarises the different thresholds of the Canadian score on the left and the low, intermediate and high risk classification by clinical judgment on the right. And you can see that the sensitivity of 70% refers to a score of 0 or less. So therefore, the team here were applying a Canadian score of 1 and above would lead to admission, 0 or below would lead to discharge, which is a higher threshold than the Canadian authors initially advocate. And you can see this leads to a sensitivity of 70%, therefore missing 13 patients. Now, what the authors don't tell us is what conditions those patients had that were missed. Whereas obviously in the Canadian external validation study, they do tell us what those patients are and tell us that they weren't any deaths or ventricular arrhythmias, but we don't have that information here in the EMJ paper. So at the moment, the jury's out on this. The clinical decision rule of the Canadians seems to be very promising. It certainly risk stratifies patients across the range of scores, and very clearly there's a rising risk for increasing score, but where we put that cutoff to try and have maximum sensitivity without omitting more patients isn't clear. And I think we probably need some more external validation studies here, much larger studies, and also in many more populations. I think it's important to put a bit of context around the change in methodology in some clinical decision rule research over the last 5 or 10 years. Previously, in the 90s, studies reported a 30% one-year mortality for patients who were thought to have a cardiac cause for their syncope in the ED. And this really highlighted syncope as a high-risk ED condition. However, this review in the ESC guidelines for a few years ago in the appendix, which looked at over 10,000 patients from 13 studies, showed that 1 month mortality is actually less than 1%. And although 10% of patients have a non-fatal severe outcome, in 2/3 of these patients, this non-fatal severe outcome is apparent in the ED. And only in 1/3 of these is it not apparent in the ED. So syncope research now is very much moving towards only including patients in whom we don't have an underlying diagnosis in the ED. So while these studies suggest that emergency physicians compare well to clinical decision rules, we know that we're still not great at identifying those patients who go on to have a cardiac cause identified for their syncope after their emergency department attendance. This graph is taken from a study our group did 3 years ago, which was where we put a 14-day ambulatory patch on patients who came to the ED whose syncope was unexplained after their ED workup. And we asked the treating ED clinician to rate the likelihood of the patient having a cardiac cause for their syncope from 0, which was least likely, to 10, which was most likely. And you can see that when we went on to look at whether the patient had a major adverse cardiac event, that the patients who were rated by the ED clinician as less likely certainly had less MACE, and those that were rated as being more likely to have a major adverse cardiac event there was a higher incidence of MACE. But clearly there were patients who were deemed to be 0 out of 10 chance of having a cardiac cause who had a cardiac cause. And equally, there are patients who were rated 8, 9 and 10 for likelihood of having a cardiac cause who in fact didn't and had a benign cause of syncope identified later on. The next question is, if the emergency medicine service, medical service or paramedics are bringing the patient to the emergency department, once the patient arrives in the triage area, can we safely decide whether the patient is safe to go home and therefore save admission to the ED and overcrowding and unnecessary investigation? And this is the focus of this study, which was published in the European Journal of Cardiovascular Nursing, which looked at a emergency department hospital in Murano in Italy between 1st of Jan 2017 and the 30th of June 2019. All patients who presented to the ED with syncope were classified prospectively into whether the patient was a high-risk patient or a low-risk patient according to the European Society of Cardiology guidelines. They looked at 2,066 patients who presented in this time, and they classified 14% to be high priority according to the ESC guidelines and 86% to be low risk according to the guidelines. They then assessed the patients at 30 days and looked at the likelihood of cardiac syncope and found that this was present in 7.5% of patients at 30 days. The nurse triage showed a sensitivity for cardiac syncope of 45% and a specificity of 88%, which showed that the ED team were not great at being able to safely rule out and discharge patients with a cardiac cause, but were reasonably good at detecting patients that are more likely to have a cardiac cause. They felt that because of this suboptimal sensitivity, this using the ESC guidelines or sort of other clinical decision rules is probably not safe at emergency triage settings. But they did wonder whether using, for example, precise scores or ECGs, which are commonly not available in triage in most emergency departments, could maybe triage the performance. But certainly, as they were at the moment, this probably wasn't a safe way to discharge patients from the emergency department without them being assessed. Next, going to move on to this large international multi-centre study which aimed to look at the impact of recurrent syncope on death and major adverse cardiovascular events, so MACE. This group from the Basel 9 investigators, collaboration with multiple sites across Europe, enrolled 1,790 patients who were over 40 and who presented to the emergency department with syncope which had occurred in the previous 12 hours. They adjudicated syncope etiology by having 2 independent cardiologists to look through all of the patients, and they found that the incidence of recurrent syncope within the first 24 months was 20%. Now, interestingly, there has been some previous studies that have shown that recurrent syncope is associated with a more benign outcome, certainly sort of 10 to 20 years ago, and there have been a few more recent studies that have questioned this and have not shown this benign nature of recurrent syncope. And interestingly, this study confirms that. They found that patients who had an adjudicated final diagnosis of cardiac syncope had an increased risk for syncope recurrence, and recurrent syncope also carried an increased risk of death with a hazard ratio of 1.87 and of major adverse cardiac event of 2.69, although this was a time-dependent effect. So you can see here on the infographic that more than 3 episodes of previous syncope inferred an increased risk of syncope recurrence. If you had cardiac or unknown syncope, you had an increased risk of syncope recurrence. And if your syncope recurred within 8 months, you had an increased risk of death. And if your syncope recurred within 12 months, you had an increased risk of major adverse cardiac events. So the investigators here concluded that recurrent syncope rates are substantial, and they vary according to syncope etiology, with cardiac causes leading to an increased risk of syncope recurrence. And importantly, recurrent syncope carries a time-dependent increased risk for death and major adverse cardiac events. There's not a large amount of new research in the field of biomarkers. We know from work over the last 10-15 years that some cardiac biomarkers such as high sensitivity troponin, BNP and NT-proBNP are able to risk stratify patients for syncope, however, are not particularly good at this risk stratification when you remove confounding variables such as multimorbidity and previous cardiovascular risk factors, age, hypertension, for example. Although obviously the Canadian syncope score does include troponin, and this is the first decision rule, apart from the Rose rule, which used BNP to incorporate a clinical biomarker in its risk score. So I wanted to touch on the European Society of Cardiology guidelines for the diagnosis and management of syncope, which are several years old now. They have a whole section dedicated to the ED management of syncope, and specifically the risk stratification of syncope according to the presenting complaint in terms of the history, physical examination, ECG changes and past medical history, and have low and high risk features. There are some papers now that are looking at incorporating the ESC guidelines and looking at their effectiveness. This is a study from Holland, which looked at 101 patients who presented to the emergency department with syncope and looked at whether following the ESC guidelines made any difference compared to standard care. The study found that generally treating clinicians didn't follow ESC guidelines, and one of the main reasons that they fell down was that they didn't always incorporate orthostatic blood pressure, which they only measured in 40% of the patients. When they compared the diagnostic accuracy of the initial treating clinicians, if they were using standard evaluation versus ESC evaluation, they found that using the ESC approach resulted in a diagnostic accuracy of 80% versus 65%. And this mainly was affected through better history taking. So this demonstrates something that we've known for a long time, that the importance of taking a good history and making a good diagnosis in syncope is to focus on very thorough history taking. The importance of this and the importance of a standardised evaluation has led to this group looking at developing a syncope app, The QR code there takes you to an app which you can download. This screenshot here shows the app taking you through a standardized patient assessment. Once you have completed aspects of the history, the patient's examination and other findings, it gives you a ranked differential based on those and recommends the next step, and then also gives you a risk stratification of the patient in terms of whether they're low risk or whether they're high risk and are at risk of cardiac syncope. To emphasise the importance of history, how can we not include this case report from the EMA, the Emergency Medicine Australia journal, in 2005, featuring me as a 25-year-old medical student having just qualified and on a tour of New Zealand, with a very impressive trousseau sign after a transient loss of consciousness during a tandem skydive. On the face of it, pretty concerning. Potentially an exertional syncope. We jumped out of the plane at 9,000 feet, became vertical at 5,000 feet when the chute opened, and at 4,000 feet I had a transient loss of consciousness waking up on the ground. Luckily, it was a tandem skydive and not solo, so I lived to tell the tale. Here is me, 15 minutes later, with much less grey hair than I do now, and neurologically intact, although maybe some disagree. This demonstrates the importance of a clear history which gives us the diagnosis here of venous pooling caused by reduced venous return caused by the straps worn for a tandem skydive. I should make it clear that I'm not suggesting for 1 minute it should be mandatory to experience the condition you have an academic interest in or to feature in a case report on it. I'm not going to focus on clinical examination at all in this talk, apart from to mention this case report, which very clearly demonstrates the importance of a cardiovascular examination, especially an examination to look for the murmur of aortic stenosis. This is a patient who gave a clear history of abrupt loss of consciousness, having just completed a run, who was found to have severe aortic stenosis. So just to emphasise the importance of a clinical examination, including a cardiovascular and focused neurological examination. This brings me on to the next couple of areas I want to look at. And I'm going to focus on some papers that look at the benefit of guidelines and also the benefit of rapid access syncope clinics. These are both advocated in the guidelines. This is an example of a care referral pathway that we use in IED. And it's also just worth reminding you that there are some advice sheets for patients with vagal and postural syncope, which are available as part of the ESC guidelines, and very helpful to give out to patients that you see in the ED with these causes for syncope. The ESC guideline emphasised the importance of good follow-up and also having a rapid assessment syncope clinic. This study by Lara Mitchell in Glasgow looks at an embedded rapid access syncope clinic. The Glasgow RASCL has successfully reduced admission of low-risk patients. It provides appropriate follow-up for intermediate risk patients, and it reduces the length of stay for those requiring admission to hospital. It's vital that these specialist clinics are run by syncope experts who can pick out the nuances of the patient's story, not protocol-driven like most ambulatory models. Another study looking at the benefit of a syncope unit and also of following the ESC guidelines is this Dutch study that had 3 phases to it. They recruited 264 patients and found that the guideline led to good diagnostic yield and a good accuracy, and they didn't miss any serious outcomes. Interestingly, they found that the main driver to the diagnostic yield was the history-taking phase, which led to a diagnosis in 94% of patients, and it was only the autonomic function tests that added an extra 3% to this diagnostic yield. So again, another study emphasising the importance of good history-taking. Looking at whether we can bring some of this expertise into the emergency department, this study from Roseanne Kenny and colleagues in Dublin examined the impact of an emergency department falls and syncope service, which was bedded into the ED and saw patients of all ages with falls, syncope and dizziness. The study was a cohort study looking at a 3-month period in 2018 prior to the implementation of the ED falls and syncope service, and comparing that to a 3-month period in 2019 after the implementation of the service. The findings were that there was a low admission rate for patients presenting in 2019 compared to 2018 of 34% compared to 27%. The mean length of stay for patients who were admitted to hospital was reduced from 20.7 days in 2018 to 18.2 days in 2019, and there was also a reduction in readmission rates within 3 months of the index presentation from 21% to 16%. So the authors felt that this study showed the benefits of having this multidisciplinary falls and syncope service embedded within the emergency department, not only for identifying high-risk patients, but also for identifying low-risk patients who could be rapidly triaged to discharged or to a ambulatory care style pathway. Just before I touch on the next paper that I was going to summarise for you, I thought I'd just remind you of the ESC traditional pathophysiological model of syncope, which divides syncope into 3 main classifications: that of reflex syncope, orthostatic hypotensive syncope, and cardiac syncope, which we can divide into arrhythmic and structural cardiac causes. The authors of this journal review suggest a more innovative approach might be useful here, and rather than thinking of vagal syncope or reflex syncope and postural hypertensive syncope, that we divide non-cardiac syncope in terms of blood pressure and ECG monitoring findings into those patients who have a bradycardic syncope phenotype and those patients who have a hypotensive syncope phenotype. And they suggest this might be first part of our thinking of syncope more in terms of a personalised approach. So this might be something that we see a little bit more of in the next few years. Taking this personalised medicine approach further, can we better direct care and investigations to patients in the ED who we may feel are at risk of cardiac syncope, particularly arrhythmic syncope? And this is one question that the Canadian syncope researchers have thought about, and they propose a 2-hour monitoring period in ED for patients who are low risk on the Canadian rule, and 6 hours monitoring in an observational unit or in an ED environment, followed by 2 weeks of ambulatory monitoring with review in an ambulatory medicine setting, for example, for those patients who are medium or high risk on the Canadian syncope score. And using this strategy, they found that they detected 50% of arrhythmic outcomes within 6 hours of the ED presentation and 92% within 15 days. And they felt this supported a 2-week outpatient monitoring strategy for those patients that were medium or high risk according to the Canadian rule. I think this strategy gets to the heart of the problem. In ED, we want to do better than just trying to identify potential high risk patients. And we need to be trying to diagnose these high-risk cardiac causes, both structural and arrhythmic. I've touched on the patch ED study already, where we took 86 patients with unexplained syncope and fitted them with an ambulatory patch ECG monitor, the Zio XT patch, which continuously records a single lead ECG for up to 14 days. And we compared these patients with a standard care historical cohort of just over 600 patients who had no obvious diagnosis in the ED. We recruited 86 patients, 76 returned their ECG patches, having worn them for 14 days. 56 of these patches recorded a diagnostic finding. Of these 56, 34 showed normal sinus rhythm or ectopics only during symptoms, but 9 patients recorded a serious arrhythmia during symptoms. So we decided this study demonstrated the patients whose syncope is unexplained after ED assessment do have a significant burden of disease, and we feel this is frequent enough to warrant further investigation. The significant arrhythmias occurred right up to 14 days, further supporting the Ottawa Group's 2-week outpatient monitoring strategy. And to take this forward further, we have recently managed to obtain a large grant from the BHF to fund a UK open-label randomised controlled trial of immediate 14-day monitoring versus standard monitoring in over 2,000 patients presenting acutely with unexplained syncope to see whether this approach reduces syncopal events, a very patient-orientated outcome, over the next 2 years. Hopefully, when I stand up before you in 4 years' time, we'll have the answer as to whether an early diagnostic approach using novel ambulatory technology is the correct one. To finish, I'm briefly going to touch on palpitations. This is a common problem we see in the ED with over 300,000 presentations a year to UK emergency departments. Most patients who present to us have had a palpitation episode which has settled. We have a normal ECG when we're assessing them in the emergency department, and there's little we can do really apart from discharge them and tell them to present either back to us or to their GP when they have further symptoms. Therefore, to better care for these patients, we set up a multi-centre randomised controlled trial to look at a smartphone-based event recorder, in this case the AliveCore device, alongside standard care in patients who present with the emergency department with palpitations or pre-syncope, to see whether this device was able to increase diagnostic yield for palpitations. We recruited 243 patients. There were 57 female patients. There was a wide range of ages, and most patients presented with palpitations, although we did recruit some with pre-syncope. The headlines for this study were that of patients in the intervention group, the symptomatic rhythm detection at 90 days was 56% compared to only 10% of patients in the control group. What were the symptomatic rhythms we were picking up? Clearly you can see about 85% of these are sinus rhythm, ectopics and sinus tachycardia, and the other 15% are cardiac rhythms such as atrial fibrillation and flutter and SVT. Time to diagnosis was reduced in the intervention group, so 9.5 days in the intervention group compared to 43 days in the control group. We looked at detection of symptomatic cardiac arrhythmia specifically at 90 days and found 11 patients in the intervention group had one of these diagnosed compared to only one participant in the control group. The intervention was cost effective. Patients were satisfied with this, and this led us to set up a smartphone palpitation service in Lothian. We found that 93% of participants in the IPED study who did record a symptomatic rhythm during the 3 months of the study did so in the first 28 days, and therefore we brought most people back within 28 days and sent them away again if they hadn't recorded a symptomatic rhythm during this time. The service was established in July 2019 and based in our ambulatory care unit. We initially saw ED and acute medicine referrals and reviewed the patients at 4 weeks, which enabled efficient use of the device and turnaround, as well as timely treatment of those patients who we recorded a symptomatic rhythm. And we looked at the first year findings in our clinic setting. During this time, 290 patients were referred to clinic, 282 reviewed in the clinic, and 237 had the device fitted. We made 17 cardiac diagnoses, and we diagnosed a further 200 patients with a non-cardiac diagnosis. So what cardiac rhythms did we detect? 10 atrial fibrillations, which were by far the majority, some patients with SVT, and also a smattering of patients with atrial flutter and atrial tachycardia. Very similar to our findings in the IPED study, and very similar to other studies that have looked at this in the outpatient setting. Where are we with the use of event recorder devices in palpitations? Well, the NICE Medical Technology Evaluation Programme has recently published a guideline for the use of the CardioMobile, suggesting it reduces time to AF detection. It's simple and easy to use. Recordings can be taken to GPs or looked at the end of a specific monitoring period. It improves quality of life because we diagnose patients early and we treat people earlier, and it's also cost effective. To summarise, a whistle-stop tour there through some of the latest research in the areas of syncope and palpitations. Take any questions.